Good morning, everyone, and welcome to the Voice of NASOMH, Solutions for Navigating the COVID-19 Storm. This is part one in a two-part series. Today's part one is how to leverage data capacity as a solution when you don't have a lot. I will be your MC this morning, Sunny Lou Williams with TechServe, and supporting our transitions between the presentations provided this morning by President Vivian Leslie Bibbs with NASOMH, Dr. Andrew Miller with The Ohio State University, and Chip Allen, Director of Health Equity of the Ohio Department of Health. As we see multiple folks still in queue to sign in, we'll give everyone a few minutes to jump on the GoToWebinar platform, and then we'll hand it over to President Vivian Leslie Bibbs with NASOMH to give an overview and welcome on first part series. We've got several attendees still signing on, so we'll give everyone just a few minutes here.
Good.
And for those that have signed on, if there are any issues with audio connectivity, we do have tech support standing by, so feel free to either chat into the webinar platform or email us at info@techserve.io, and our tech team will be standing by to help you get connected. All right, for those that are just joining us, we're giving everyone just a few more minutes to sign in before President Vivian Leslie Bibbs of NASOMH gives her welcome and introductions. And again, for those signing in, if there are any issues with audio or if you're unable to view the presentation, please let us know by either chatting into the webinar platform on your lower right-hand corner or by emailing us at info@techserve.io, and a team member will be with you to get you connected.
Sunny, I should have asked this before we get started. Are you going to be monitoring the chat so people can put in questions at that point?
Absolutely. I will help to moderate any questions coming in. If there's a natural break, I'll go ahead and direct the questions. If not, then we'll save the questions for the end of the presentation.
Thank you.
And good morning again for those joining us. We are giving those that are still signing in just a few minutes to get acclimated. And again, if you have any issues with audio or viewing the presentation slides, please connect with info@techserve.io via email or simply chat into the bottom right-hand corner of your screen any issues that you may be facing, and our tech support team will be.
I also was noticing where a few people were saying that their state agency was blocking this platform. So you might want to mention too, Sunny, that this will be archived if they're having a problem viewing it, that we'll make sure that the link goes out that they can follow up and watch at a later date, because I'm seeing those flash across my screen that people's this platform's being blocked by their IT support at their agency. So
I see. Yes, absolutely. We will have the webinar recording published via web link, and also will be updated to the NASOMH website. And as we finalize the webinar presentation and also the recording, we will post both onto the NASOMH website.
Thank you.
And we also have quite a few folks that are registering now that are joining. So I believe let's go ahead. It is 11:06. Let's go ahead and get started.
Yes, let's.
Wonderful. Well, I'd like to introduce again President of NASOMH, Vivian Lasley Bibbs, to do the welcome and introduction for our two-part series on the voice of NASOMH, navigating the COVID-19 storm.
Morning, everyone. Thank you for joining us this morning on behalf of NASOMH. We're ecstatic and happy to present our two-part webinar series. It's going to be some great information that I think is going to be invaluable to all our state offices. This has been in the making in a while, and I've talked to at least one of the presenters at great length about the importance of knowing how to leverage the data that you do have, how to make it talk, how to present that in a way where when you have your seat at the table, you're coming ready and showing where resources need to be placed, where emphasis needs to be placed and prioritized. And I think you're going to enjoy it. I won't take up a lot of time since we're a little late getting started, but I do think I want you to come back for part 2, because we're going to go in greater depth and talk about how this data can be used to inform policy, how to drive future decisions, not just as it relates to COVID, but for other health inequities and social injustices that we see across the country as state offices of minority health. So I won't belabor, but I want you to look at our website. If you want to become a member of NASOMH, there's information on there on our website on how to do that. We welcome you as we work to address health inequities and social injustices across the country. I want to go ahead and introduce Johnny Chip Allen, who's the Director of Health Equity for the Ohio Department of Health. He's going to be leading off today, and then he'll be followed by Dr. Andrew Miller, Program Director of the Kerwin Institute for the Study of Race and Ethnicity, and Assistant Professor of Practice at the College of Public Health at The Ohio State University. I want to welcome them both this morning, and I'll turn it over to you.
Thank you, Vivian. Good morning, everyone. Thank you for attending this webinar. And in the beginning, I just want to say a special thank you to our president, Vivian Lasley Bibbs, who her leadership has just been incredible during this time. And she's worked very hard to put this webinar together. I also like to thank the past president, Antoinette Holt, who also was very instrumental in coming up with the idea of such a webinar to talk about data. And I'm just really happy to present with my colleague and friend, Dr. Andrew Miller. Before COVID-19, we had never met. I think we met about 4 months ago. And I've spoken with him pretty much almost every day in the last 4 months, as he's helped me really think through some very difficult data issues, and to be able to help me really, I think, thrive and to be able to make a better contribution to this whole COVID-19 response. So I'm just really happy to present some ideas with him, and hopefully you'll be able to take the information back to address the COVID-19 issues in your area. With that in mind, go to the first slide. So as we advance, thank you. And so in terms of learning objectives, I really want to just talk about a few things. Number one, there are a lot of different data sets that are currently available to you right now that allow you to not only understand COVID-19 strategies, but think about populations made vulnerable through challenges of social determinants of health. And so a lot of times when we try to do this work, one of the things that stops us is where can we get the data and how can we make this data relevant to our reality? And to do that, we not only have to think about how COVID-19 impacts the general population, but again, who is most at risk of COVID-19? And also, I want to just be able to talk about that when you have the good solution, how can other states really work together to share solutions so we don't really have to reinvent the wheel? And so if we have, again, covered these points, it would be really great. But then also one other point in terms of learning objectives is that when you've done all that you can and that you are maybe at your ends with in terms of how do you maximize the data, what partners can you use? Who can you go to help validate the good ideas that you already have, but you may not have the expertise to really reflect that with data? And so that's why I think that you see some of the amazing work that Dr. Miller has done. Next slide. And so, in starting out, I'd like to just call attention to a letter that our president, Vivian Lasky-Bibbs, wrote on March 15th. And it was an important letter that I, as well as many of the other NASOMH individuals, received. And it talked about what we could expect in national offices of minority health or health equity as the COVID-19 epidemic or pandemic progressed. And one of the things she talked about, again, in terms of these points, is that the COVID-19 response fell short. What could we do to raise the awareness of the needs of marginalized communities to whoever in your state is leading the charge? She talked about unfair opportunity structures and how the folks that are most marginalized in our communities will require a different response. She talked about the need to being able to advocate, first of all, not only being at the table, but also being able to advocate about how social justice issues really will impact the pandemic. And then she really talked about how the months ahead would really test the resilience of our offices. And in this letter, she also talked about how those of us who work in offices of health equity can provide solutions where no solutions currently exist. Next slide. And so this letter was extremely important and helped me think about that. But no more than 3 weeks later, after our president of our organization wrote this letter, we began to start seeing headlines in the national news. Perhaps you saw this in your state and in your newspapers as well. And it was talking about how racial ethnic minority populations and those who are economically disadvantaged, we talked about how African Americans and other racial ethnic minority groups were being disproportionately impacted by COVID-19. This was in all the headline news. And so, for those of us who work in minority health and also in health equity, this was no surprise. We knew that this was going to happen before it hit the headlines. Again, 3 weeks before the headlines hit, our president had actually predicted this and tried to prepare us. Next slide. And again, going back to the letter, the president said, if the COVID responses fall short, offer solutions. And in doing that, we know that there are online resources that actually can help you really begin to start crafting data and using data, turning data into information that will allow you to actually have a response for this pandemic. So one of the things I like to do is to talk about, again, the CDC Social Vulnerability Index, the 500 Cities Project, the CARES Engagement Network, and ArcGIS online. And the reason I want to show this is because in many cases, many of our national offices, or even our state offices, minority health and health equity, or maybe even if you are at a community-based organization, you may not actually have a budget to buy sophisticated tools or even actually hire somebody to do this analysis. Thankfully, these resources exist, they're free, and the one big thing or the one common feature about all these tools is that they allow you to conduct some type of spatial analysis based on social determinants and also based on disease entity. And so I'm going to go into this just a little bit more. Next, please. So this slide actually has a little animation, but I want to just be able to look at this just very briefly, one by one. Next. Next. So the Social Vulnerability Index is a very good tool because what it allows you to do is actually look at vulnerability on at least 4 different indices, and it allows you to actually map social determinants and also the resilience of individuals before, during, and after disaster. You can actually go down and really map a community's of vulnerability to the census tract level. Now, a lot of us might be we're used to dealing with zip codes, and zip codes are okay if that's all that you have. But zip codes are primarily, they primarily are good for the efficient delivery of mail. But you can't compare sometimes one zip code to the other because they're not designed for that. Census tracts are. But this is, and so this is an example of how I took the CDC Social Vulnerability Index, and I was able to identify in Hamilton County, primarily around the city of Cincinnati, Ohio, census tracts that would have the highest vulnerability in regard to a human cause or natural disaster. I was able to do this math in about 5 minutes with ArcGIS Online. Next slide. Next, and so this is the 500 Cities Project. And the reason why this is important, this is, of course, is at CDC. And I like how CDC has made this available because they can actually allow you to choose major cities in your area and be able to understand where the COVID-19 underlying conditions exist down to the census tract level. So what you see here is a map that I was able to produce. And I was actually able to look at asthma, chronic kidney disease, coronary heart disease, COPD, and diabetes. And I was able to actually find out where did all of those underlying conditions exist at their highest levels at the same time in Cincinnati, Ohio. I was able to do that with this online resource. The next is the CARES Engagement Network. This is another tool, and the reason why I like this tool, number one, it's free. But it also not only allows you to create a map, but not only can you create a map, and of course, all these examples are in Cincinnati, Ohio. But once you create a map, I think this is, I'm reflecting one of the chronic diseases, but it allows you to create a number of different reports and it will allow you to query the data so you can pinpoint exactly what areas you need to focus on. Next. Another free tool, this is ArcGIS Online. And the reason I want to show you this is because ArcGIS Online, it allows you to actually not only take a lot of these data sources, you can actually pull them up within ArcGIS Online through this tool called the Living Atlas. But you can display different layers of data at the same time. It's a very powerful tool. They have versions, of course, that you can pay for. All of these tools are available to you right now online. And this is what I help use to make my case for COVID-19. Next slide. So here's an example of how I use the 500 Cities Project next to be able to identify those areas in Youngstown, Ohio. Next, please. And one of the things, the reason why this is important, because if you remember, when the COVID-19 pandemic first hit, and we heard through our health alert networks what was going on in regards to these underlying conditions. It was very easy for me to take that 500 cities data, all of these images that you see on the left in terms of these underlying conditions were taken directly from that 500 cities data source. I was actually able to determine what census tracts or neighborhoods were had the actual not only highest levels of these diseases, but what I was also able to do with these tools was determine those census tracts that had every one of those underlying conditions at their highest level at the same time. And then based on those available tools that I talked about, I was able to understand exactly what racial groups would be disproportionately impacted, as well as being able to understand within those census tracts how many people. This slide is really important because not only did I do that for Cincinnati, I took these same online tools and I was actually able to run this analysis for all the major cities in Ohio. And that was based on, that was in the 500 Cities Project. We talk a lot about disparities and they're important, but as you look at these maps and how I created them with these free online tools, one of the other things that you'll be able to see is that we talk about health inequity, health disparities, but you also actually have can you go back just for a second? You also actually have a situation where there was health inequities because, can we go back to the previous slide? Because one of the things about this, if you look at this in the patterns in every city in which I conducted this analysis, where I looked at those underlying conditions with their worst levels, you see that in the majority of the cases, African Americans are the group that has been disproportionately impacted. So not only do we have a problem, but we have a systemic problem in every major city. So this allows us to be able to ask the question, what could we be doing differently knowing this information before the pandemic hit? Next slide. And again, we have other tools that we were able to use to say what's driving these health outcomes out of control. Excuse me. So we have a tool called the Health Opportunity Index that my colleagues at the Virginia Department of Health helped me walk through to understand how to create such a resource. But you can actually take the Social Vulnerability Index, again, that free tool, to begin to understand what social determinants seem to be reflected in the areas that you've identified. Again, all this with the free tool. Next slide. So what happened is that as we began to start developing these insights and tools, we immediately start to share them with all of our partners. So on the upper right-hand corner, you actually are able to see how I took the Health Opportunity Index and then used it, I think, in ArcGIS online, that free tool. I just went to the Living Atlas, said I want to see the Social Vulnerability Index, and then using some of the tools in that resource, I was able to show census tracts that actually in around Ohio that had the highest vulnerability, and that means I wanted to know what neighborhoods reflected the least resilience to be able to survive a human-made or a natural disaster. And I think I was able to identify I was able to identify millions just within this whole tool right there. And then as I began to use these tools, I knew that a lot of my partners in local health departments and community-based organizations didn't necessarily actually have maybe the tools to do this when the pandemic first hit. And so we start immediately creating these tools for like Akron and Cincinnati and Cleveland, and we sent them to folks very early in the game. The other thing I was really lucky is that I was able, my agency had asked myself and another colleague, Tiff Huber, to create a vulnerable population report, so to speak. And so within about 4 days, we gathered a number of individuals, physicians, researchers, community-based personnel. Director Angela Dawson from the Ohio Commission on Minority Health was instrumental in helping review this. But we put together a report. And then based on that report, we were able to even get better insights. The whole point of me saying that is that not only did I take these free online tools and was able to create reports, I was able to share them with other folks to make sure that, I wanted to have someone validate my findings and then make sure that I wasn't missing anything. And as soon as I did that, I shared these resources as widely as I could. Next slide. And so the thing is that I am good at GIS, but I also knew that there were some things that I needed to understand beyond my capabilities. And so what happened is that on August 3rd, our chief information officer approached me and said that they had a data source that were significantly richer than the ones that I had been using. And I listened, and sometimes I was thinking, oh, my data is good enough. But sometimes you have to put your ego aside and to be able to listen to what people are saying. I'm glad I did, because what I was able to do is to find out that there was a resource, a data source, that allowed me to take the information that I had already compiled and go down to the household level. But in order to do that, in order to use that resource, I know that I needed a group of folks to actually be able to help me think through data and think through issues that were beyond the skill set that I have. And so I was able to put together a team of Ohio-based equity and data science experts. Of course, Dr. Miller was introduced to me at that time, and he came on board and really began to help me think through this data. So we worked with the Deloitte team to be able to take the data that I already had, and then with their insights to create something that was new and improved and something that we'd never seen before. But the way that this worked is that I actually had to be able to trust the insights of people from a variety of different backgrounds, even different than my own. Next slide. So as you start thinking about using these available data sets and then being able to work with either a private organization or even researchers, the first thing that we actually had to do is we came up with some key questions and decisions we need to make. So we wanted to be able to know, for example, where were these households where the underlying conditions were really bad, but these folks who maybe didn't have a doctor, they couldn't socially isolate safely, or they had limited resources. At that time when we started, our governor was talking about the need to increase testing. So we want to be able to ask a question, where should we concentrate COVID-19 testing for those not only who are at the highest risk, but how does that lead to us being able to determine, for example, communities that need to then locate, once you test someone and they're positive, how do you create resources and safe spaces for the population to safely quarantine? At that point, we had local community organizations who wanted to pass out safety kits. So our questions were, where could we take this data and provide data to our local partners to say, if you want to pass out safety kits of hand sanitizers and face masks and information, where should you do that where you can get the most bang for your buck? And so based on these decision points and these questions that we came up with, we were then better able to not only use our data more effectively, but then that of our partners. Next slide. And so I think this is the time where I will hand it off to Dr. Miller. But one of the things that we did is we took all these insights and we came up with something very different. And to let you know exactly how we did it, I'll just pass it over to Dr. Miller to explain the other part of the presentation.
Thanks, Chip. Appreciate it. Thank you, everyone, for having me. And Chip, I cannot express to you enough gratitude for how appreciative I am to have gone on this journey with you for the last 4 months. We have, as Chip explained, I was brought to the table through some pathways through the Ohio State University to work on this. And by the time I had joined the group, Chip's analysis had been distributed. And one of the questions, other than the questions that we had just shown in the previous slides of some of the things we wanted to learn, was how do we scale this up to the entire state level? How do we provide the entire state with opportunities of understanding where vulnerable people exist, regardless of race, ethnicity, socioeconomic income? We wanted to make sure that everyone who needed help could receive help. And so we identified vulnerability. That was our first step, was to define vulnerability. And so we did that by understanding where the high prevalence of COVID-19 underlying medical conditions were. And we just kept using what Chip had already had available, which would be diabetes, COPD, high blood pressure, and asthma. And actually that we later replaced asthma with hypertension, among other things. But we used those four main comorbidities, and then we, following the same basic qualitative assessment that Chip had used, we overlaid that on top of what we defined as vulnerable working populations. Now, as we have come to realize, poverty level has a lot to do with identification of vulnerable working populations. But we also wanted to understand exposure. And so we started to define who vulnerable worker populations were. And what happened? Am I still here?
Yes, Dr. Miller, we can still see you.
Okay, I have no idea what happened to my video, but that's fine, no worries. We identified who essential workers were first. And in the state of Ohio, the essential workers were identified as food service and accommodations, healthcare and social services, manufacturing based upon executive orders, and then also transportation and warehousing. We also wanted to understand who was going to be vulnerable based upon when Ohio reopened. And by the time that this had come out, our first iteration of our vulnerable census tracts, we ended up taking a look at people who were in entertainment and recreation, administrative support and waste management, educational services, and then other services that service-based organizations would be providing, as well as retail. And when we went back to our partners at Deloitte, they were able to quantify for us that our definition actually went slightly beyond where their definition would have cut off, but it was at least 85% match with what they had come up with. And so all the census tracts across the state of Ohio that you see here in red are in fact those areas where we had at least one comorbidity in the top 40% of the population across the census tract, on top of once again, the top 40% of what we defined as vulnerable populations. Now, from there, we teamed with our partners at Deloitte to identify households that couldn't properly socially distance or maintain separation where there was crowding. We took a look at characteristics of census tracts and households that wouldn't be able to weather long-term social and economic upheaval, but also identifying where critical resources and services would be provided, such as hospitals, grocery stores, and other transportation needs. Next slide, please. Next slide, please. Thank you. So here's what we came up with. And so when we had our 702 vulnerable census tracts, you can see the distribution is all over the state of Ohio. What is hard to see are the areas within urban areas. But it is a point of importance that we identified that of those 702, 290 of them were rural census tracts, 198 urban, 161 suburban, and 53 small town. This equates to over 2.3 million people in the state of Ohio. And when the state of Ohio has roughly between 9 and 10 million people, we're talking about a quarter of the population qualifies as vulnerable. Next page. So we started to take a look using the Deloitte Insights, some of the various locations that would have very interesting conditions and characteristics that we would have to address specifically. But we also found out when we looked at the urban counties that more than half of those geographies have those census tracts, more than 14.8% of the population within those vulnerable census tracts in the urban areas were actually vulnerable households. Franklin County itself had 3 highest density census tracts that we saw across the state, but they all had populations of over 2,000 people. Hamilton County's three highest density census tracts had over 1,500 people, whereas in some of the rural areas, the census tract populations were much smaller. But we also wanted to identify within that data set whether or not we would be examining high levels of what we called minority majority populations, populations where there'd be people of color, immigrant and refugee status, residents living with disabilities, and so on and so forth. Next slide, please. And so if we zoom in here to some of the, or to the four major metropolitan areas, Dayton withstanding, we can actually take a look at this distribution of vulnerable populations. And they are highly concentrated in the urban core that has been routinely disinvested since the 1960s and 1970s. But additionally, it's in the outlying areas just beyond the suburbs of most of these major metropolitan areas. And the one thing that most of what we see here is a concentration of poverty. And also in the cases outside of the suburban regions, along the rings of outside of Toledo, outside of Cleveland, Columbus, and the city of Cincinnati, we can also see that there is a diminished population density that where they're not able to support necessarily some of the services that are absolutely needed during this COVID-19 crisis. Next slide, please. During this crisis, Deloitte also came up with identification of specific census tract populations. And if we took a look at just the urban areas, these were the, as you see in the table here, the area, the census tracts within the state of Ohio that were the highest percentage of people were identified as vulnerable based on their household data. And as you can see in Census Tract 29 of Franklin County, almost 32% of the people in that census tract were identified as vulnerable, as having at least one of the four comorbidities that we use to identify vulnerability, along with being part of a vulnerable workforce population group. Hamilton County came in after that, and frankly, that Hamilton County Census Tract 8601 was less than 4 or 5 blocks away from where I lived in Cincinnati during the 2000s, during the aughts. And this continued all the way through. And these findings were cross-referenced with the CDC Social Vulnerability Index and also the household data of created by Deloitte's Health 360. Next slide, please. Now, when we take a look at the some of these urban locations, we find that there are a lot of very interesting findings, such as in Tract 29 in Hamilton County, there wasn't a lot of people that were living above the age of 65, only 8.5%. Compared to both urban and state averages, that was very low. And yet the percentage of homes with crowding was at least 2.5 times higher, where minority populations, this was a specifically minority majority population, well above both the urban and state averages, with high levels of poverty, high levels of, moderate levels of uninsured populations, but no access to vehicles. Next slide, please. Compare that with the rural counties, and we found a preponderance of counties in southern, south central Ohio, in what is the Appalachian region, throughout Adams and Adams County and Brown County, and then Meigs and Scioto counties. Once again, these percentages of vulnerable population, as defined by our group, were still high according to state average, but not nearly as high as the urban cores. However, if we go to the next slide, please, we will also find that their characteristics were very different from the urban cores, such as they had a much higher percentage of people living above the age of 65. And even though it was a rural county, that was still below rural county averages and still below state averages. There was no crowding in homes. There was very few people of color, very few minority groups, but yet, once again, people living in poverty was a very huge factor, as was the percent of uninsured population in these census tracts. And once again, no access to vehicles. This created a very different set of conditions that we would have to address if we were to go in and provide resources identified by testing populations. And so that led our group to understand that we really needed to create a holistic approach to how are we going to reach out and address vulnerable populations in different portions of the state of Ohio that would have different needs. Next slide, please. And so with our Deloitte partners, we directed that we wanted to take a look, and I know that this map sometimes looks like a hot mess, but I'm going to try to walk you through this. All these triangles represent census tracts across the state of Ohio that have at least one testing site. And all the blue dots are household level findings according to Deloitte's data that represent vulnerable households across the state of Ohio. And you can see that in a lot of cases, these triangles overlap where we see there are a lot of testing locations, but you can also see that there are vast stretches of Ohio where there are no green triangles, and there's a lot of vulnerable people, including that corridor running from Michigan all the way north-south from Michigan down to Cincinnati, and also all throughout the southern tier of Ohio through Appalachia. And this leads us to some very interesting findings. Once we started to plot these data and compare them against growth percentages and growth rates of COVID-19 cases at the county level throughout the state of Ohio, we started to see that there were areas such as Adams County and Meigs and Scioto right through the southern tier, at the southern tip of Ohio, that really are in need of some resources. But we can also see that there are a lot of areas, as if we zoom in, within the urban cores that just are not receiving the needs that they absolutely require. Next slide, please. So we took the 702 and we identified where we needed to put testing sites. And so all the gray areas, all these gray census tracts, were part of the 702 census tracts that did not have a hospital or a known testing facility within, I believe it was 1 mile of their boundaries. So these are areas, these are census tracts that do not have testing available to them. And even when we take a look at whether it's urban or rural, these were large populations that are not able to access transportation per se, at least private transportation. And with as communicable a disease as COVID-19 is turning out to be, do we really want people to actually travel by public transportation to go receive testing? So the idea was that we would identify mobile testing sites across the state of Ohio. Now, I went through and tried to create a geographically distributed data set across the state of Ohio to at least try to provide all of much more complete coverage geographically speaking. Now that created a list, and those suggested locations are the areas with these little yellow dots, which I understand may be a bad color choice, mea culpa. However, we came up with a list of 36 locations. Next slide, please. And these 36 locations are covered over, I believe, 28 different counties, both urban and rural, all throughout the state. And we identified high schools, fairgrounds, and in one case, a Menards distribution center to come up with locations where people could go to receive testing that would be within, hopefully, a preponderance of vulnerable people within the state of Ohio in some of these underserved locations. Next slide, please. We seeded 6 of these locations to Deloitte for Deloitte to create their own list of mobile testing site locations. And what we found was that Deloitte was going for more bang for the buck. Where would we identify the most amount of people that we could reach with these mobile testing sites? What's interesting is that about 13 of these locations that they came up with, of the 25 that they created, 25 to 28 that they created, were either the exact same location or within the same neighborhood as what we came up with our list. Now, if we take a look, one of these areas in Columbus would be Linden McKinley High School, and as you can see here with the yellow star, these are all in the red dots households that represent vulnerable populations. And using Deloitte's household data, we identified that within 1 mile, there were over 6,000 vulnerable households. And we even had that broken down by race and ethnicity, by crowding, which is people with 4 or more people within the house, non-English speakers, and no vehicles. And this number right here, the no vehicle number, 3,900 of that 6,600 vulnerable people within 1 mile of Linden McKinley High School. These are individuals that would not be getting into testing facilities nearby because they weren't nearby. They'd have to take public transportation. Compare that then to Eastmore Academy, just to the east of downtown, and you also have over 2,700 individuals who are vulnerable within the households. And then of that, 1,700 of them did not have access to cars. And yet the bus line exists way up here at the very top of that census tract, where you see a line in that lower red dotted image. That bus line is way up there. So, and along the highway that has the designation down here at the bottom, we would not have had a lot of people who were out sick, potentially with COVID-19 conditions, that would be walking up to a mile to get to that bus stop. These are definitely locations of need. Next slide, please. The Deloitte data came up with a way of identifying so much information for us. It was data-driven approaches and validation of the methods that Chip had originally been creating and working with 500 cities data. We expanded that data set. We expanded into additional characteristics of the people who were living in these vulnerable population groups. And we were able to ask not only where to provide this information, where to provide testing, but how can we provide culturally specific guidance to at-risk communities. And we can then specifically tailor all of those findings to people that need assistance. Next slide, please. And this is where we started to get into the work of some of our colleagues, Dr. Juliana Nemeth of the College of Public Health, Dr. Kiera Barnett of the Kirwan Institute, also at Ohio State University, Dr. Dina Chisholm from Nationwide Children's Hospital and Ohio State School of Medicine, and along with some other individuals throughout the Ohio State community and over 50 volunteers to assess this information. We identified that if we are going to provide testing in these areas, it would actually be morally wrong for us to stop at the testing and not provide additional services to these populations, whether they be urban, rural, suburban, small town, whether they be Black, white, Hispanic, Latinx populations. We needed to make sure that we provided all these services that would come along with the testing. And so Dr. Nemeth led a group that actually created a social survey that got over, I believe, 300 different responses from across the state of Ohio, identifying specific needs for all these different vulnerable census tracts across Ohio. Next slide. And from there, Dr. Nemeth, as well as the rest of our group, believed that it was very important to make sure that these services were not necessarily provided by agents of the state, but rather by local public health departments and also local not-for-profits and other organizations that work on the ground in these census tracts where trust has already been created, so that we can get a whole lot more done with trusted agents. That way, next slide, please, we can hit all the different needs of people, whether it's at the base socioeconomic factors, making sure that people have proper nutrition, all the way up to counseling and educational services to make sure that we really truly meet the needs, and not just the basic needs for basic health care, but all needs to address some of these systemic that do not allow for people to seek access to resources that they need, so that people can improve upon their socioeconomic status, but also their health, with their health being the foremost goal here. But honestly, as we have come to realize, next slide, please, you can't just isolate any of these things. And so from a neighborhood assessment perspective, and our esteemed colleague, Dr. Jason Reese, formerly of the Kirwan Institute, but now within the City and Regional Planning Department at Ohio State, made sure that we understand that while we can address some of these medical and health related issues, and that may have a ripple effect to all these different areas in and around this circular framework of neighborhoods, that we have to hit multiple spots along this entire continuum, around this entire coliseum of needs, to be able to affect positively neighborhoods that have been routinely disinvested. Next slide, please. And so some of the intermediate interventions that we have come up with was centering community voice and leadership in the decision-making process, making sure we can improve the built environment, expanding access to quality care, asset building for residents, and that's a huge deal at the Kirwan Institute, is making sure that we can provide and help build assets for all disinvested communities, for all people, specifically these minority majority populations in the urban core, but also extending out to some of the disinvested areas in rural areas as well. Next slide. And so some of the stuff that we had come up to identify and to create was to make sure that we could, using the Deloitte 360 household level data, is to create flyers, letting people know and assess whether or not how they can engage with this free testing. And so we can put out potential flyers and pamphlets and postcards to make sure that the community knows of what is available. And next slide here. And this is where we need to sum up, and I invite Chip to chime in as well. What we have come to find out is that there are two different levels of takeaways that we have found throughout this collaboration. And these both hit on the personal and professional takeaways side, and then also on the clinical takeaways side. On the personal side, the number one thing we can make sure that we communicate is, please, everyone who is here on this call, you are in your position for a specific reason. Trust what you know. Your experience, your knowledge, it cannot be used enough. Do not let anyone tell you that it is not sufficient. On the same note, please follow Chip's example. Don't be afraid to admit what you don't know and where you may be wrong. And then also network with other local resources. And this is one that I can specifically speak to. I have not been on the clinical side with Chip and other people at the Ohio Department of Health. I've been on the university side since 2006. either as a graduate student or a professor at various universities throughout Ohio and Michigan. Universities are some of the best assets you can access. There are always people like me that are looking to make an impact. Sometimes we are able to volunteer and donate our time pro bono. For something such as COVID-19 and the statewide responses, that is going to be a little bit different. But I can tell you from my experience at Saginaw Valley State University in Michigan that all I asked for was to pay for my students' time. And if I had to request payment for my time so that I could get a course release to help drive this coursework and drive this work, I made sure that I was able to pay that back on the end, such as finding additional funding through other grants to continue this work. There are people like me all throughout the United States, not just at the big universities like Ohio State or the University of Michigan or even Cal Berkeley. Look at some of the local regional universities, such as Saginaw Valley State University, Central Michigan, the University of Cincinnati, Miami University. We exist there. Please do not hesitate to ask. This is the kind of stuff that academics want to be involved in. And also, it also very much helped at the end. We all have to understand why we're there. And Chip's questions, his formulation of guidance was honestly absolutely critical to our success so far. The academics, the team members from ODH, as well as Deloitte, all put their egos aside. We learned from each other. We made sure that we admitted what we didn't know, admitted what we didn't think of, and addressed the problems as a whole. It was, this has been one of the best work environments I have ever participated in. Chip, do you have anything else to add?
Yeah, thanks. I agree with everything that you said, Andrew. And I think that, you know, one of the things, and I go back to Vivian Lassibette's letter in terms of saying, what happens when you're not at the table? And the thing is that sometimes when you're not at the table and you have to invite yourself, sometimes it may make you doubt what you know. And the reality is that, as Andrew said, we're in these positions for a reason. And the thing about working with Andrew and my other colleagues, it amplified my voice in the way that wasn't amplified before. And one of the most gratifying things that I could tell you is that, you know, when Andrew and some of our other colleagues began to start taking the other data sets, they really affirmed what I already knew. They actually validated the work that I had already done, but they took it to a whole nother level. They helped me take it to a whole nother level. And so there were some things that I did that were good, but working with them made it so much better. And because of this, the other thing we also realized is that COVID-19, as a novel virus, there are things that we still don't know. We know that the way that we've been working together, because I think Andrew and I, with the rest of the team, we talk about 3 times a week. We know that this is not sustainable forever. But for right now, our collaboration and using what we know and coming together and understanding what we don't know is really what is needed to respond to this pandemic. And, you know, and only good things are going to come out of it. And even if we disagree, we make sure that we understand why we're disagreeing and we can come up with a way of understanding, well, what can we agree on to move the work forward? So I'll just stop there and maybe, Tony Lou, we can open it up for questions if there are any.
Absolutely. Dr. Miller, Chip, thanks for such a comprehensive and very clear methodology on not only the data study, but also the impacts of how that study then resulted in COVID-19 screening and ultimately impacts to information generated from those communities of greatest social vulnerability index scores. We've got a tremendous number of questions. We've got 15 questions that we'll outline as part of grouped towards outcomes-oriented, methodology of data study, conceptual, and then finally resource questions. So let's start with the outcomes-oriented. Some great questions pertaining to the data that resulted. Once these specific systemic issues were identified, leading towards the social vulnerability index, the specific census tracts that were identified for additional social determinants of health, what recommendations were made moving forward to address the upstream or root cause of the vulnerable areas identified?
I'll start with that, of course. And one of the things, many of our states and many of our partners have been either invited or assigned to these strike forces, sometimes at the state level and many times at the local level. But these strike forces were put together very quickly to address the disproportionate impact of the COVID-19 pandemic on racial and ethnic minority populations. So the first thing that happened is that as many of these strike forces or task forces were designed to inform the governor and policymakers on what to do, I was assigned to one of those strike forces, as well as other colleagues on this Ohio team, Director Angela Dawson, the House Commissioner of Minority Health, Dr. Dina Chisholm, just to name a couple. And we took these findings and this data and we shared it with the folks who were actually leading the strike force to say, we know we have a large task in front of us, and when we're thinking about vulnerable populations and even minority populations as part of that vulnerable population group, these are things that you can apply right now to be able to deal with these downstream, midstream, and upstream issues. And we also, and like one of the things we came up with in terms of the strike force, the minority COVID-19 strike force in Ohio, is we said that the data need and the policies that should happen beyond COVID-19 is to put together a interagency group to address health equity on a long-term basis beyond COVID-19. So, and while we had been actually advocating for that for years, it was this type of data and these recommendations that allowed us to push more longer upstream solutions in a way that we probably would not have been able to do if it wasn't for COVID-19.
Thank you so much, Trip. Very, very specific details surrounding the impacts of this study. In addition to those directed actions resulting from the data study, what are some policy and advocacy strategies that would be recommended by your team with the results that you have in front of you?
Well, I think that our colleague, Dr. Juliana Nemeth, can probably speak to that best, and she is not here at the moment. However, I can tell you that in terms of policy, in terms of testing, some of the things we've advocated for is to making sure that, because there have been some ideas floated about it as to who's going to, say, administer the testing. And it's critically important to understand that if we want to make sure that we can get people tested that would routinely not have access to testing or wouldn't seek out testing for whatever reason, but particularly migrant populations in rural parts of Ohio, we may need to make sure that we have that testing created and worked through, say, as a policy, as a practice, through maybe some a local not-for-profit that addresses migrant worker needs. In Michigan, I would go through the Mexican American Alliance. My good friend Bobby De Leon there, who works with the Latinx community in Saginaw, in the Saginaw County region. I would, if I was in Michigan, I would go through there. I'm going to apologize first and foremost. Most of my experiences in the health domain have existed within central Michigan, and I've only just recently gotten to Ohio State in the past year. I know some of the groups I would target in Michigan. In Ohio, OLA is a group I would work with to possibly facilitate that testing. So as a practical policy or application of a suggestion, that's where I would start.
As you have listed out significant partnerships by state, I think it's also important for our audience members to identify their key legislators, key policy constituents, and really identify areas of opportunity as data sets are being presented of what additional funding and also resources can be directed towards counties and also specific cities and census tracts. Thank you for that comprehensive review. As we look further into outcomes-oriented based questions, specific questions pertaining to how do we prepare our most vulnerable populations in the most vulnerable counties and census tracts? How do we prepare them based upon this data set for future pandemics, future health crises, and future social determinants of health concerns? Where are there essentially methodologies and or specific operational tactics that can be deployed to support all organizations supporting social vulnerable individuals?
I'll start by saying this, is that at the Ohio Department of Health, our job is to be able to provide the resources so that our local partners can develop locally driven solutions. And so I think that, part of when we start thinking about resources and tactics, this is something that I've said, and I want to make sure that it's not taken out of context, but I always tell folks that the state health department cannot come in and save communities. Only communities can save themselves. The state health department has a specific role and responsibility to make data and resources and technical expertise available. But we also have to also be able to respect the fact that while we can provide data and other insights, it is very important for us to respect the talent and the solutions that are community driven. And I think that that's one of the things that a colleague, Dr. Juliana Namath, had mentioned, is that there are local community-based organizations that need to be given the resources and this information to make decisions. And so, the way that I want to just at least follow up on this question is to say that whatever we have available at the state, we need to make it available not only to our local partners, but we have to also listen to what they have to say and follow their lead, because they're the ones that are actually living and addressing that. So those tactics should always be locally driven and locally directed.
I would concur.
Excellent points, Chip. Thank you.
Oh, sorry. I would say if you're looking for university partners, look for departments of planning, departments of geography, and departments of public health, and even departments of social work to assist in the planning portion of that if it's deemed necessary.
Great, thank you both for the key insights on ensuring that local communities are supporting and connected with state agencies to help continue the work. Let's move on to the methodology of the data study. Some key questions here surrounding how the partnerships are formed, costs, and so forth. One key question is, how did Deloitte obtain the household level data? Was that a survey that was conducted by Deloitte, or was there a business transaction data or government economic data? Was this organic, or was this sources sought?
So I will say that their data source is rather robust and complete. It is not, I will tell you that some of it comes from subpostal route identification. Some of it comes from Medicare and Medicaid services provided. It also comes from various other market share estimates. But I can tell you from having former students work in this field, they pretty much know what you would be interested in buying, pretty much because they have credit receipts for the household at the household level and subpostal level. They know what you're buying, and this is coming from all of their individual partners. So when they say that the likelihood is that you have 5 people in your house, chances are you have 5 people in your house. Their data source, frankly, scares me from a privacy standpoint, but their complete knowledge or complete estimates probably provides us one of our greatest assets in being able to produce usable strategies and methods to work for positive effect and change in particularly underserved communities.
I think
In addition to that, one of the things that we learned, and I think our partners like Andrew and Kira Barnett and some other folks pointed this out, is that, just the Deloitte data is incredible because one of the things that I did not have in my arsenal is the ability to go down to the census, to the household level. Some of the data sets that I use that we license at the Ohio Department of Health at best allow me to go down to the census block group level, but not at the household level. But one of the things that we also found by working with our partners in Deloitte, that there were some of the ways that they had identified vulnerability did not match what we actually were identifying in terms of like the social vulnerability index or the 500 cities data. And so what happened was that when we start putting all of our assets on the table, in some cases, I know that Deloitte went and readjusted their model because they realized that the way that they sliced the data was so fine that it was really leaving out some areas that we had identified. But by adjusting their model and then also by actually reworking some of our assumptions, we were actually able to really amplify the power of all these different data sets to really get at a level of precision that we couldn't have done by ourselves. The other thing I would say, and this was a health equity, well, this happened with the 500 cities data. The 500 cities data was absolutely extremely important in terms of us being able to take, because if you go to their site, you can look at the data by state and county, or you can go down to the census tract level. Extremely powerful, but it's only available for the 500 largest cities. So what happens when you're trying to do a health equity analysis and you want to go in terms of a rural area that you don't have any 500 cities data for? So to that, right before the epidemic hit, I licensed a data set called a policy map. And it took the same methodology, the small area methodology the CDC uses, but they were able to extend that for all census tracts in the state. And that really helped us get some of the estimates in terms of the smaller areas that were not in 500 cities. And that really allowed us to be able to identify vulnerable census tracts, particularly in the rural areas and the smaller areas. So we had to actually use a number of different data sets in addition to Deloitte, which is still very valuable, to really be able to come up with the areas that you've seen on the map.
There's a great number of questions regarding the actual data set that was provided by Deloitte. Was this the Deloitte Consumer Insights data set?
Yes, that was one of the data sets that they utilized. They've also got other additional medical models for individual disease curves and whatnot that they are now consulting with the CDC in terms of increasing their accuracy of their predictions and assessments at the county level for across the entire United States. We actually made a lot of suggestions as to how to address some of what we identify were some missed populations within those models being created for specific medical comorbidities. That is now being shared with the rest of the country. Honestly, I think that may be one of the best things to come out of this partnership is the fact that we've had so much give and take and understanding of that. And I got to give a special shout out to my colleague, Dr. Kiara Barnett of Kerwin, who, among others, and once Kiara and I were able to start to expand and explain what data was missing from those models, it really opened the floodgates to other conversations with Deloitte on how to improve those models. But yes, the consumer insights was one of those data sets, but also there are other individual medical models.
It seems like
I just want to add to something that Andrew said, is that that was the first thing that Andrew and Dr. Kiara Barnett understood, is that some of the critical data was missing. And I'm not sure that we would have arrived at that realization that quick or even at all had they not been at the table. And that's why you really need, again, partners, researchers, folks who have skills that you don't have, because we may have made some incorrect assumptions had they not seen that that data was missing.
It seems that this was a tremendous big data study as well, and looking at the collaborative data sources that needed to be pulled together to make really targeted census tract-based decisions in not only planning and logistics, but also in directed support for the populations that needed immediate emergency COVID relief. When we look at this type of collaboration, was this particular project produced resulting in a no-cost collaboration, or was there fees to accessing both Deloitte's team and the data sets?
You want to start, Andrew?
I will say that the members of the Ohio State University team that was provided to Chip and the Office of Health Equity at ODH, we donated our time pro bono to this point. We have all of these findings were done that way. There was an all-call put out by the university. People were identified by deans and department chairs and volunteering to get the right skill sets to the right locations for help. The extension of this project is probably going to require some financial resources to the university, especially as classes begin and our time becomes more compressed due to courses and other research. But Chip, I'll let you speak to the Deloitte.
Yeah, so it was interesting because our CIO had initially identified the Deloitte data set because they were working on some recovery issues, and it became available to me. However, one of the things that I had discovered, quite recently, is that there was some preparedness money available that we could use to be able to augment an existing contract. And so one of the things is that while I appreciate and I'm internally grateful to our university members who have donated their time pro bono, we can't expect them to always do that because of other priorities. And so I've recently been made aware of resources that I am using or I will use to be able to, maybe starting in August, being able to provide some type of compensation for folks because, number one, it's the right thing to do. Number two, the resources are available. But number three, and I really want to make sure that I say this, is that a lot of times when researchers or folks are doing things on behalf of vulnerable populations or minority populations, there is an expectation sometimes that will be done for free. And while I do appreciate the fact that, for at least in the beginning of this, it was done without any expectation of compensation, we have to be able to find ways to be able to compensate folks who are working in this field for their time and expertise, like other folks are being compensated. And so when I realized, just by happen chance, that there were resources that I could tap into to be able to help, with this partnership, I jumped on it, and will continue to do that when it's possible, because we're getting hundreds and hundreds of thousands of dollars, really, in terms of technical resources and expertise that we should be able to compensate for. And so there's a lot of preparedness monies that I wasn't aware of, but once I was made aware of them, we're making resources available to these folks that have been helping.
Chip, I think that's really well stated as far as the available resources regarding funding, and then also the ongoing collaborative efforts that are needed to stave off future pandemics or future concerns, and in general, looking at resolving the existing social vulnerability indexes that were there even prior to the pandemic. I think from the audience point of view, many have chatted in and said that, of course, they also wholeheartedly agree that this is worth doing and worth buying. But truly simplistically, wanting to understand costs in order to not only lobby for the resources, and then as a part two to that, not only understanding the costs, but really understanding an instructional model of how they could replicate utilizing not only the free and open resources that you mentioned earlier, but then also collaborating on a more extensive design, specifically with non-free or non-open data sources that would then be required to really do that deep dive onto the direct census tract level. Do you have next steps in consideration of creating an instructional guidance and understanding the cost of the project so that other states could look at and understand what resources and what staff time is needed to support this?
I would, my first response, I want to say is no, but then I will say there is a way to do this. And I'll add Andrew's that, because here's the thing. When I found out that resources were available, I didn't go to Andrew and colleagues and says, this is what I got, take it or leave it. This is what you get. This is what I got. And, what I said was, can you give me a figure of what would it take in order to fairly and equitably compensate the other colleagues, and then he came up with a way of actually being able to do that. And in terms of the instructional piece, I think that's something that we need to think about, because I can say this: as we have shared some of these insights with other colleagues, even at my federal partners, particularly like the insight reports and those of the testing, I know that it got the attention of some of our colleagues at the Federal Office of Minority Health. So I think that we might have to think about how to write this up, but to be honest, things have been happening so quickly. We just got a request, and rescue me if I'm wrong, Andrew, but we got a request for data on minority, we got a request that says, could we put testing resources that would be able to address the migrant farm community? And we literally had to turn that around, I think, in 2 days, right? So I'm saying that, so the thing is that when we start talking about the cost of things of that nature, I think it has to be something that you would need to negotiate. And you have to negotiate not only based on what it would take, but also the resources that you have. But Andrew, I'll let you also chime in on this.
Yeah. I think if you're looking for low-cost solutions, I think your best bet is our short-term partnerships. And a lot of times, academics are willing to do things for free if you can give them access to data. Because frankly, to us, data is the most precious commodity we can come up with. And especially when we're dealing with the idea of public health, so much of that data is so hard to come by. And honestly, if Chip had come to me and it was 3 months down the road after everything else is done and said, hey, we've had a request for this, what can we do? I would flat out say, for something like the migrant housing facilities across the state, I would have said, you provide me access to X data, I will definitely be able to do this for you. But I'm also going to tell him what my timeline is going to be. And academics are notoriously slow. We work on a different timeline than almost anyone else. And benefits to that, and there's drawbacks to that. And sadly, that's the model. We are there for research and education, and we want that. If it's going to be a long-term project, something that is going to go on beyond just a few small deliverables and whatnot, and it's going to go on for months, and there's advise and consent that's needed. Yeah, there's probably going to be a price tag associated with that. I can also tell you that by working through offices of sponsored programs at universities, they're usually pretty good at identifying individuals that are looking for specific types of projects and who has expertise in certain areas. Reaching out directly to deans and assistant deans within colleges that the work resides in. Worst case scenario, call a geography department and see who they know, because geography departments know everyone. That being said, I think it's a usable model. It's something that's helpful. But I know there's so much work to be done on this. And we're right now in the middle of redeveloping the vulnerable census tracts, and it's a vast undertaking. I just showed Chip the preliminary results yesterday, and while we think the data is the appropriate data to be looking at, we know we have to go back and start from that modeling process from scratch again. And to deal with complex issues like COVID-19 or inequitable social determinants of health and their distributions across not just geographic spaces, but also demographic spaces. These are complex problems that are going to require sometimes some tricky modeling.
The other thing too, just to add to Andrew, is that timing is of the essence, because right now, this happened when they were in summer recess. But again, when classes start up, and whether or not universities go online or whether or not they have some type of hybrid approach, time is going to become even more of a precious commodity. The other thing that you might be able to entice researchers, academics, is the ability to publish, the ability to talk about how could we replicate this, or what lessons did we learn. And so I think that that's also an opportunity, but just also remember that COVID-19 provided a number of opportunities to collaborate because we had to, but also remember that there are other things that have happened during this pandemic. So we remember we now had like the Black Lives Matter movement occurred during the midst of this pandemic. And I think that when you're doing something like this, other issues will emerge that could reflect, or at least can impact how you go about doing this work. And so as you're thinking about engaging researchers and engaging community folks, and then you have these other large issues occurring, I would just say that you need to be flexible, because the more flexibility that you can have in incorporating other schools of thought or other issues that arise, I think that's going to allow you to attract the type of team that you need to address this in a comprehensive way.
Chip and Dr. Miller, thank you both so much. We've heard a fantastic overview of the work and efforts that you both and your collaborative teams have done in really peeling back the data sets and better understanding the impacts of the community at a directed local level. We have 15 additional questions that have come through during this time, but we are unfortunately out of time. What I'd like to do is to recommend and highly encourage those that have brought in further questions to really consider these 3 key takeaways. As this phenomenal model has been shared, the data sets, the origin sources, and also specifically additional data that's been brought in through surveys, assessments, et cetera. How do we account for replication of this model in your own home states? And then 2, how do we account for truly a center of excellence from a technical assistance perspective of bringing together what Chip and also Dr. Miller have put together and their collaborative teams to truly step-by-step instructionally support a deployment of this? What would that particular innovation and center look like from a technical assistance? Is that something that the National Association of State Offices of Minority Health, as not only a member organization, but also as a convening organization, could support and model? And then finally, how do we continue the good works that are supported today through very, very fast, rapid turnaround funding specific through COVID-19, as we look at continuous reduction of health disparities by, again, addressing pinpointed data and opportunities to motivate additional tactical and operational changes, and again, local level technical assistance to support this work. So let us again thank Chip and thank Andrew, Dr. Miller, to account for their presentation on the model, and let us think through as we pursue webinar 2, moving from data to policy and advancing the health equity collective by partnering outside the traditional public health sector, as we continuously put forth more efforts and more brainstorming on how to replicate the good work that has been exemplified in the state of Ohio through all other 49 states. We thank you for your time today. We encourage you to register if you've not yet for Wednesday, July 29th, which is the second part, starting at 11 a.m. Eastern. Again, Chip and Dr. Miller, thank you so much for your presentation and for your time today. The resources, the presentation, and the video will be available on the NASOMH website shortly, and a updated follow-up link and evaluation survey will be sent out to all as soon as that video and presentation resources are posted. Thank you so much. Have a safe and healthy rest of the day. Take care, everyone.
Thank you.